and welcome back to the Foot and Ankle Clinics podcast. I'm Megan Ashdown, the managing editor for the series here at Elsevier. Foot and Ankle Clinics is a quarterly publication with each issue focusing on a single topic in foot and ankle surgery. Today we'll be interviewing Dr. Bruce Sangerosen, UW Medicine Professor of Orthopedics and Sports Medicine, and the Director of the VA Center of Excellence in Limb Loss Prevention and Prosthetic Engineering. Here now is the consulting editor of this series, Dr. Cesar de Cesar Neto, to lead the discussion, along with a member of our editorial advisory board, Dr. Francois Lins.
Well, thank you. Thank you, Megan, for the organization. Thanks, Dr. Sangerosen, for accepting the invitation and for being here, spending some time with us. It's always a huge pleasure and honor to be with him. We were just together in Vancouver for the AOFS meeting. Francois Lins, thanks for joining as a co-moderator. Francois is one of our associate editors for Foot and Ankle Clinics. And I think we jumped right in, Dr. Sangerosen. We have a lot of interesting questions for you, nothing tough, but this is a very easygoing chat here. And basically, I think the way for us to start here, we can start kind of jumping some steps, skipping some steps here, but I gave in my talks, you probably saw me talking about it before, that if you think you're doing something new and innovative, it's because you never read Dr. Sangerosen's papers, because he probably did that about 30 years ago. So how did that start? I mean, where did you get your ideas from? How did you start your research interests? Did that come from college times, even high school times, in terms of being inquisitive, and then residency, medical school residency, etc.? But tell us, how did you jump into such innovative things that you did throughout your career?
Well, thank you for inviting me. It's a great pleasure to be here, and especially talking to a couple of young, smart guys that can straighten me out. In the trauma world, we always said, if you think you're doing something innovative, it means you don't read German. So that expression, I think, carries on a little bit. I did get interested in research in undergrad. I went to the University of Michigan, where even kids like me who had no significant educational background were invited into the Honors College based on an SAT score, and a requirement of that process was doing a research thesis as an undergraduate, a baccalaureate thesis. So I started doing it then, and imagine no internet. Imagine having to get all references by personally walking to the library and carrying that reference to the photocopy machine. And there was no Publine. So if you wanted to find papers on a given subject, you would go through the monthly printed version of all publications in academic medicine and go by author, go by topic, go through, mark the page, then go find the journal, then carry it to the copy machine. So doing research in those days was a little bit more rustic, but I found myself very often getting lost in the source documents, because I would read something and I'd say, that doesn't make sense. So you go back to read where the source of that comment came from, and often find that it was a review article, just someone's opinion. So that had a little bit of a dent on my psyche, because I wanted to know that things that we're referencing also have been documented with some kind of measurable metrics. And I ended up at Harborview because I couldn't decide what part of orthopedics was most fun, so I chose trauma. And when I came to interview for my trauma fellowship, I discovered that Dr. Hansen had an interest in foot and ankle mechanics, which was a surprise to me. But I told him that in my trauma rotation, I was so often faced with a circumstance where severe injury had no references available on how to treat it, no guidelines, no data. And I told him I would be doing a foot fellowship after my trauma fellowship, and he said, don't go anywhere else, stay here, I'll teach you about foot trauma and foot in general. So that's how I got this start with him. And he was very much an engineer at heart, and he didn't accept anything that some eminent personality told him. He always wanted to make sure it made mechanical sense, which is also a great leap to me, because I felt the same way. And during my trauma interview, I actually sketched out a triple arthrodesis that I had done after coming back from the AO trauma course. I talked my attending into letting me use screws to fix a triple arthrodesis because the prior one that we had done didn't go well, in my opinion. And he let me do it, but I couldn't find a good way to put a screw from the calcaneus to the talus. So Hansen just took my sketch and drew where the better place to put the screws was than what I had picked. So I knew I was going to learn something there along with my trauma fellowship.
Wow. What right place, right time, right? That was meant to be.
I think so. A lot, as I mentioned at the meeting this weekend, most people didn't know Hansen did foot and ankle surgery, but he was very interested in it and had an adult foot and ankle clinic and a pediatric foot and ankle clinic. But at the time, he was a little bit banned from the American Orthopedic Foot and Ankle Society because he was doing heretical things like putting plates and screws in foot and ankle deformities, and that was not well accommodated to the culture at the time.
Yeah. Look where we are. Look where we are. That's very interesting. Francois, you want to do a follow-up on that?
Well, I would like to ask a question to Dr. St-Georgian about trauma, because I come from a place in France called Alsace. It's very close to Germany. And throughout my training, I've been very much acquainted with intramedullary nailing. And I read that Professor Hansen was, one of the guys that really liked the concept. And you said he was an engineer at heart, and he was one of the ones who fought for intramedullary nailing. And I wanted to hear from you. I guess this would be kind of the same period when you guys started working together. I wanted to hear from someone who had been very close. How did that go down? How did he go about bringing this concept over to the US? And I guess somehow fighting for it.
Yeah, it was much more of the latter than the former. So I'll shorten this story as much as I can, but in 1963, President Kennedy of the United States was assassinated. And the poor house officer who was on call at the trauma hospital in Dallas, which wasn't actually a trauma hospital because they didn't exist, was so affected by that event that he spent the rest of his career trying to improve trauma care in the United States. And that was 1963. He finished his residency in the late 60s, and he had been pulled to University of Washington in the 1970s. Around that same time, Hansen was a resident in the 60s, and a visiting Japanese fellow who was here for a year told the chairman here that there was a guy in Germany that was putting intramedullary nails in, and they invited Kunstler to come to Seattle. I think it was around 1964 or 1965 while Hansen was still a resident. And his chief resident, a guy named Smith, went to Germany for 3 months, learned how to do intramedullary nailing with Kunstler in Flensburg, and then brought the equipment back in his suitcase to start doing that at Harborview. Hansen simultaneously had already begun experimenting with AO things, like, for example, the paper on open fractures of the ankle that was complete heretical back then. So he had one foot in the AO world, and he had also been exposed to the intramedullary nail world. And simultaneously, the Orthopedic Trauma Hospitals Association started, and Harborview was one of those. And that's when the chair of general surgery became a trauma surgeon, and Harborview, prior to that, was just a county hospital and then decided to divert into a trauma center. So he was in the middle of the intramedullary nail world, the internal fixation world, and the development of a trauma program here and around the country. So he just happened to be in the right place in the right time. And as Francois just said, he was someone who would be very comfortable promoting ideas that weren't accustomed and that made people feel uncomfortable if he believed that they were true. And he ended up taking over the intramedullary nailing program when Dr. Smith left for private practice. The first 50 nails in the United States were done by Dr. Smith at the University Hospital, not at Harborview. And then when Smith left, that all moved over to Harborview, where Hansen was partially running the trauma service. So it's another case of the right place at the right time. But the AO, as you know, was not supportive of intramedullary nailing. They believed in primary fracture union with rigid fixation. So he was pushing from both directions at the time because the AO was not supportive of the concept.
Was going for what made sense, right? Both sides, what made sense in both sides. Yeah, very interesting, fascinating. We're going with, we have a lot of curiosities about you, Dr. St. George, and so we're going straight to the things that fascinate us. But, you know, I think you're so accomplished research-wise in so many subjects. I'll just, we were looking into your publication that, you know, total ankle arthritis is definitely a big one for you. Foot and ankle trauma is a big one for you. But of course, I'm very biased to all the flat foot stuff. What does Dr. St. George likes the most? If you were to choose like your contributions to the literature in one specific area, which one would you choose and why?
Well, I don't have to choose because Google Metrics can tell me what other people are interested in. And oddly enough, my most frequently cited paper is neither of those. It's a triplane osteotomy that I wrote when I was a resident. That paper is not so much cited in the US because people fix tibias here, but much more frequently downloaded in the third world and second world. And that's a paper I literally wrote with the help of my brother, who was a mechanical engineer back a long, long time ago. But if I was going to pick a clinical field, I would say I'd be perfectly happy if all I did was cavus foot, planus foot, ankle arthritis, and calcaneus fracture. If I just did those 4 cases, I'd be a happy man. I don't need anything else in the OR to have fun. I think cavus foot is the most interesting single problem because everyone is a little different. There's so much motor imbalance plus bony abnormality that you have to sort out. So that's by far the most fun. And I started doing simulated weight-bearing CTs in 1993 or 1994 because I just couldn't figure them out by looking at plane films. And that was before 3D printing, of course. So you couldn't print one. You couldn't reformat a CT as a 3D image. So you had to just visualize it yourself. So that's when I got interested in the weight-bearing CT, which then led to my interest in flat foot too.
Well, you went into one of our hot topics here, so I'll leave that one to Francois.
I think between the two of you had about 7 or 8 papers on the topic, if I'm not mistaken, this weekend.
Well, yeah. So like this is backwards, right? We're getting interviewed now. You turned it around, sir. Well, you know this whole thing about flat foot has had a lot of transformations lately with the PCFD classification you've been part of, and this is inspired a lot by your seminal works on peritalar subluxation, and for us, I mean, you invented this concept, and you found it and you published it, and we always cite the work by I've got to get this one right, Anantakrishnan. Sorry if I get his name wrong.
Dr. Anantakrishnan is just retired actually and moved into a different strata.
Well, he like this is a paper with, you know, segmentation and distance mapping. So that's like segmentation of the joint space, the subtalar joint space, you know, at a time where it just wasn't available. So talk about, you know, being an innovator. So could you tell us a bit more about how this came about? Like who on earth had the idea, like we're going to outline the joints, you know, by hand, and then we're going to stack the images up together, and this will show us the subtalar on coverage. We're desperate to hear this story.
Catalyst to that was we had gotten funding to study talar neck fractures and calcaneus fractures. And we were using this antiquated pressure mapping technique where we actually had to create a pressure sensitive paper and slide it into the joint and then load it. So we had built a loading apparatus that would allow us to displace the talar neck at increments of 1, 3, 5 millimeters and the calcaneus up to 10 millimeters and see what it did to the loading. But we cycled the loading, and we found that when we made a little hole on the medial side to put the pressure transducer into the anterior and middle facet, over time, loading would cause the foot to abduct and the calcaneus to shift and the talus to shift. So we were accidentally creating peritalar subluxation. And once we finished those studies, we thought we need to find a better way to look at this subluxation concept. And that's when we built the simulated weight-bearing CT scan, which is a very rustic device by contemporary standards. It was Randy Cheng who helped me build that device. He's a PhD in biomechanical engineering. And the ShapeMaker software we borrowed, we had on loan from a company in California that was in the early stages of making people turn into monsters in movies. So you could create a surface map by a very inefficient process, as you say, slice by slice, marking the surface, and going back and stacking those slices, and then creating a 3D map out of it. So you can do your whole processing now in a matter of moments and get all kinds of data. It would literally take about a week for each joint surface in those days to do it. But at least it was able to give us some documentation that we weren't wrong, that the calcaneus was sliding posteriorly and laterally, and that it was pivoting more around the posterior facet than the middle facet, and the middle facet was just opening. So it gave us some insight, which you've very much improved upon with your current studies in that area with full weight-bearing CT and animation.
Well, I would like to ask you, Cesar, if I may just push on with another question. There has been in 2021, Andy Goldberg and Peña Fernandez published a study in Nature Reports about the center of rotation of subtalar joints, and that seemed to indicate that the center of the middle facet was the center of rotation, and then. So I wanted your view on that, because it seems like until a certain point, the middle facet will be the center of rotation. But then when whatever needs to be broken breaks, then you get another pivot point and it changes the whole mechanics of the subtalar joint.
So the stepping back a little bit, we wrote some also kind of old-fashioned papers now about the slope of the posterior facet, and the combination of the slope along with equinus contracture causing the calcaneus to try to ride up the ramp toward the fibula. But as long as the interosseous ligament, the talocalcaneal ligament, is intact, that's going to have a mild rotatory subluxation. But once that starts to stretch and the spring ligament starts to stretch, the calcaneus can migrate farther away. There's no longer anything supporting the head, and that's when the middle facet begins to open up and sublux, I think. We don't obviously have longitudinal data to show that, but I think that's what the literature points to. And there was one paper, I think sandwiched between yours, where someone at this most recent meeting talked about the failure of that interosseous ligament. Because when you get in there to do the lateral column-like thing, sometimes it's so sloppy that you know that the ligament's not going to be able to stabilize that with a lateral column-like thing alone. So I think all of those components, slope of the joint, stability of the talocalcaneal interosseous relationship, stability of the acetabulum pedis with the spring ligament and the posterior tib, all those things have to stretch before it really starts to slide. And some of them will stop sliding when they hit the calcaneus, others will stop sliding when the sinus tarsi closes, and then eventually some of them just tip right over because the deltoid is weakened too.
Well, thank you. I would continue asking questions, but I'll hand it over to Cesar. But I must say I love the serendipitous aspect of your discovery of the concept of peritalar subluxation. So that's something I'm certain to remember and point out when I talk about the subject. So thank you for this.
Serendipity is important for trauma or for, I live in Medina, Washington, where there are 11 billionaires within a 6-block radius of my house. I'm not one of them, unfortunately, but all of those people got where they were because they were at the right age when technology was growing at an expansive rate. So it's you can be smart, but you got to be lucky too.
Well, send our regards to Bill Gates.
He's not on my social calendar this week.
Well, I was trying to avoid to get to the PCFD stuff because once we get there, we wouldn't leave. So we're trying to leave it as the final. But yeah, I think, and I tell this to every single person I give lectures, but that's my favorite paper. It's going to be my favorite paper forever, I believe. It's going to be tough to get me out of that one. But not happy with that. I think the second in this sequence of events, I think the paper talking about sinus-stars impingement and subfibular impingement is as revolutionary as the Anantakrishnan paper, just because it follows up on the concept. And I feel, and I told you that before in person, that, things got a little bit forgotten for a while. I feel bad that people let that literature go down in terms of excitement for a while. And I'm happy to play a small part in raising all that up back up. And I was looking to your the Scopus, and actually at least in Scopus, your most cited paper is about gastrocnemius recession. That I have to ask you that question because it's traditional for all the Seattle trained people. The classification one for PCFD is almost top 10 already for you. What is amazing.
Didn't know that.
Yeah, I think it's number 12 now. So it's coming very fast. So I think we did something very important that day in 2019. But when you talk about Seattle training, people always talk about gastrocnemius recession, fixing everything. And people also talk about, like, if you walk in front of Harbor View, you get a lapidus. So, what can you tell us about you?
So Dr. Hansen was not one to suppress ideas, and I felt we were doing too many gastroc releases at our institution and our fellows, but we wanted to understand the anatomy of it, and that was Steve Pinney's paper. I think that's the one you're talking about, and Christy Giovanni's paper where we compared tightness of the triceps in people with and without forefoot disorders. Both of those are in the same vein. But I kind of thought we were overdoing it. And we looked in the lab at the amount of force generated by the forefoot with and without a tight gastrocnemius. And it turns out that tight gastrocnemius was a contributor, but far from being a sole cause of forefoot disorders. And my personal observational bias was that most people with a bad flat foot couldn't get by with a gastroc. They had to have a tendo-Achilles lengthening because the gastroc was only part of the problem and the soleus was a big part of the problem too. So it's just an example of Hansen training, which is challenge the thought if it doesn't make sense and try to find out the basic root cause of things. So even though he was a big believer in the gastroc, he had no problem with me presenting data that called it into question. I think it's still a big part of the process. I think people probably don't need as many gastrocs as they're getting.
So quick follow-up on that one. So how do you currently decide when you're doing your PCFD cases? How do you currently decide? I mean, every single PCFD patient, or every single is too strong always, but majority of PCFD patients get lengthening of the gastrocsoleus complex if it is a gastric recession or an Achilles tendon lengthening. Is that true or not true? And how do you decide basically when to do each one of those?
So in reverse order, there was a paper in the pediatric literature around the time we were beginning to do the flat foot studies showing 20-year follow-up on pediatric flat foot diseases, and 95% of those patients had had a tendo Achilles lengthening. So the idea was not at all controversial within the pediatric world that a tight heel cord was associated with flat foot. But generally what we do now is do a silver skull test, and if it is fully correctable with the silver skull positive, then we'll just do a gastroc, and if it only gets to 10 degrees or less above neutral, then we'll do a TAL, and if we can fully reduce it, then we don't do either one. In my opinion, most people with a flat foot disorder have a tight triceps. It's uncommon for me not to do any type of lengthening, but we're looking for it, and if you don't look for things, you don't see them. We can also have a bias that makes us do too many of them because we don't use our equinometer anymore. We built that device to have objective measurements of dorsiflexion, but from a practical standpoint, people don't have those in their office, and the devices need to be maintained, and they're imperfect too because they don't really quantify how much of the dorsiflexion is coming from Chopard's joint.
That makes sense. Thanks for explaining, Francois.
Yeah, I would like to bounce back off that. There's the management of PCFD where I come from in Europe is slightly different, and there's a lot of mini-invasive stuff going on, like the Baruch mini-invasive technique for medial gastric release, and that kind of relates to a question that I'm passionate about: is how far do we have to go in the correction? So like one of my first PCFD patients, I was with my mentor, Professor Colombier. You must know him. He was one of the conceptors of the salto talaris. And he was with me and said, okay, this is tight, just do an Achilles tendon lengthening. And I remember following up this guy for months and months and months. And it took him about a year and a half to walk correctly again. So this is why initially I reverted back to gastroc lengthening rather than Achilles lengthening. But to sum it up, sometimes I have feeling that we should maybe aim towards bringing back people to where they were after they finished their growth and not try overcorrect stuff. So I find myself, doing PCFD cases where I still have some valgus, but I'm examining the patient when he's on the table and thinking that that's enough and I shouldn't push it forward. And I think it's one of the, probably one of the arenas for the future to better define those thresholds. But I want to ask you, like, how far are you ready to go, when you've got some residual deformity in a flexible flat foot, to correct it spot on and to really put the foot back under the ankle joint?
Yeah, I think you do have to get the foot under the ankle joint by whatever means possible. On the other hand, if you can do a minimalist approach to the medial head of the gastroc, the medial head is way tighter than the lateral. You probably get 75% of the correction from the medial head, and the sural nerve is over the lateral side. So if you just do the medial, you lower your risk of complications. That being said, it's often not enough, and you can do the vulpius. You can lacerate the fascia of the soleus. That gets you additional without really weakening, because a tendo Achilles lengthening does significant weakening. The gastroc, usually your strength is back within 6 months. So I think those are all good questions to answer. And even a better question would be, okay, we left him with only 10 degrees of dorsiflexion at the end of the operating room. Now we're going to let them walk for a year and remeasure that. Did they stretch out now that you've corrected some of the fundamental problems? And maybe they do, because you make the forefoot more stable on the hind foot, and the forefoot can stretch that way better than just the hind foot can.
Well, thank you for your answer. If I can bounce off that too, like one of my questions is, okay, conservative procedures. Now, you were the one to show that there was peritalar subluxation, and that mostly occurs when the interosseous has given way, plus or minus the spring. So to what extent do you think that peri-articular conservative realignment osteotomies alone, with or without soft tissue procedures, can properly realign the subtalar joint. I mean, can we hope that the realignment is enough to reposition that very tight and complex joint?
Well, first, I want to say, as Dr. Donetto will reinforce, I wanted to keep the term peritalar subluxation in the lexicon because I think that's fundamental to understanding it, because the amount of flatness of the foot is irrelevant. What's relevant is the heel in line and is the forefoot in line. So if you have heel at heel strike in line with the tibia, and you have the forefoot at heel rise in line with the tibia, you've probably solved the mechanical problem. So whatever means you can use to do that, a lateral column lengthening does both, but you can't dial it in. It does both in relatively equal parts. Art Manoli approached this by doing a lateral column lengthening and then adding additional valgus correction to get the heel in line. And that's a simple solution that people in private practice who don't have research labs and don't have weight-bearing CTs can make that happen. And I think we have a million questions about this, and our next step, I think, should be to do what you are doing, which is to gather a lot of data before with weight-bearing CTs and after with weight-bearing CTs, and then find out the compelling components of that do the correction, and then you can do a regression analysis to see which of them were the major contributors. I don't think very many flat feet without those stretched ligaments are symptomatic. And we know that 25% of the people walking around in the world right now have flat feet, particularly in people from sub-Saharan Africa. They have a very low arch, and it's normal. It's not a disorder. It's just normal. So separating out those two, now that we can mass market weight-bearing CTs and you have all those nice metrics that you can use to measure lines, that's the time when we could start answering those questions.
That's going to be one of my final questions. That's going to be a funny one. I'll leave that to the end. I mean, what next for you? You know, like as you're saying, I mean, you know, I can see you retiring from clinical practice in the next 10 years, probably. You don't have to tell me the date, but research-wise, and you know, I feel that I talked this to Dr. DeLand as well, because Dr. DeLand is also, you know, getting close to the time where he's going to start considering retiring from clinical practice. And I told him, as one of my main mentors, particularly for the flat foot, is that you cannot retire from research. So you have to give at least 2 or 3 years of your life for research only, because I think that no one like you guys could push this forward more. Like I you know, might be my dream, but you know, you and Dr. DeLand together could like advance this at least 30 more years by working on research only for a couple of years. What is next for Dr. St. Jordan?
I don't know, but I did lean on Scott Ellis and John DeLand to help me get the term posterior tibial tendon disorder out of the literature. That was before you got there, and that's part of that push. So I'm glad that they're still raising their voices. I've dropped out of a lot of all things. I'm not an editor for the journal anymore. That frees up about 10 hours a week. I'm no longer running my lab. So I'm not planning to slow down too much quite yet on the clinical side. But most of my research is going to move away from NIH level research because it's just too time consuming. So hopefully I'll stick around for a few years, and hopefully I won't stop doing things that are interesting, because we're lucky to be orthopedic surgeons. It's a fun field. They appreciate how much better they are in a short period of time. It's a very rewarding thing to do.
Do you have something in mind that you're looking forward to do? Come on, share with us.
Whatever I do is going to have to work around seeing my grandchildren.
Of course. Priorities first. Priorities first.
Fishing, probably.
We'll see. I think for the young folks out there, I think they should follow you too. They should get some place where they have peers who are interested, get some place where they can aggregate data, do a good job of aggregating pre-treatment data in a way that you can use later to compare. A lot easier now with joint registries and electronic medical record, but it still takes effort on the front end. And I think that's how we can defeat some of the bad orthopedic literature that's still out there.
That is true. Well, we had some. I think we covered a lot of ground here, Francois, in terms of the questions.
I still have picking up from a few things that you said here. I would like to be cheeky again. You said a few things. You said we need to aggregate data prospectively. Of course, electronic medical records help with that. Facebook helps with that. And we can all see that when you walk past a shop, you get a notification on your phone saying you should get in. There is a discount on this pair of trousers for you. And of course, they're right most of the time. And we can see the diagnostic power of these tools today if we harness that power. And I think that harnessing that power means both clinical data, so that's what the medical records do, and anatomical data. And you said something else. You said that we should find ways to mass market weight-bearing CT. So of course, I'm completely biased. I'm in love with the device, and I think it changes everything. But I also think that, and I include myself in this, but the people working on PCFD and who love PCFD or who are passionate about it are somehow guilty of this not yet happening. And what I mean by that is that we have something in PCFD called sinus tarsi and subfibular impingement. And when cone beam was first used for the foot and ankle, it was marketed as weight-bearing CT. And then so everybody saw it as a CT plus weight-bearing, but they completely forget the cone beam side of thing, where it's just like a 3D X-ray, and you can do it right now in your office, and it saves everybody a lot of time and effort and a lot of cost for generally the health system. So what would you say? I mean, you said, okay, we got to do this. We got to bring it to the mass market. But how would you achieve that?
So I didn't mean to imply that you had to bring it to the mass market. I think that there are commercial entities that can do that. But I think the important piece of it is that you get the data, whether that is patient-reported data or data from the three-dimensional measurements, and secure that as part of the EMR, because that makes, I guess this is more of a US problem, that we have so many privacy rules that we're not allowed to use Facebook to recruit patients. We are not allowed to use Facebook or iPhones to collect data unless you go through an expensive and rigorous cybersecurity process. But in other parts of the world, you can still do that. So I think if you have a group all interested in a project, you agree on what metrics you want in your electronic medical record. You agree on what anatomic things you have to include, and you store those anatomic things in a safe place. Because what happened to us in those early days of weight bearing was the scans were placed on digital tapes in the early days of digital films. And then one day, without notice, the radiology department physically threw away all those digital tapes with almost 10 years of weight bearing data on them. So you need to protect yourself and your information in the EMR and lock it in a place where they can't mess with you. And as far as promoting weight-bearing CT, I think you just keep doing what you're doing with showing how powerful those tools are to help you understand deformity.
So data. About that, if we still have a bit of time, I saw that one of your recent papers is on the salto talaris. And, with a follow-up, minimum follow-up at 4 years. And I just, what would you like to comment on this paper? I have a very personal story with the talaris because my mentor was one of the conceptors. And I was trained with it. I loved it, but it's not available anymore in France. So we switched to the Infinity. So I wanted to hear from you what you thought of this implant and the way forward for you.
So what I liked about it when it first came out is that the conical shape of the tibial fixation, along with the very much resurfacing component, could keep the implant low below the epiphyseal scar where the bone was strong. And when you tapped that conical fixation peg in, there was no movement in that tibial component. And to this day, I don't think there's another implant that has that kind of stability at the end of the surgical procedure. I also liked that the talar component was resurfacing, but it had a loading peg that would allow early weight bearing. So I think it was a good design. The implantation instrumentation was not as good as what we have now, but I think it was a great implant, and I stopped using it not because something better came along, but because the technical things with companies being sold from one to another, you lose tracking of the components and of the quality, and that was the reason I switched. But I still think it's a good component as long as the surgeon has enough experience to put it in properly.
Of course, we cannot let you go being this innovator that you are, and everything that you did 30 years, 40 years ago with, tools that now are more advanced and allowing us to do, again, what you did a long time ago. What are your thoughts about AI and machine learning for what we're doing? So what do you think is going to be the role? And we talked about data, and of course, it's going to include combining data, but how do you see all this revolution of AI and machine learning helping us in orthopedics?
It's, of course, a double-edged sword because garbage in, garbage out. But I think there's an immense opportunity there. I've already seen papers documenting that AI using imagery can equal or beat very experienced dermatologists in determining whether a skin lesion is malignant or not. And it far excels the skills of younger in less experienced people. So I think we certainly will be able to use images because those are objective, and that can give us vital information when fed into a machine learning environment. And once we get better data, then it'll help us with decision making. I don't think we have good data for most of our decision making that can be driven by AI. I mean, we basically break it down into a non-AI algorithm most of the time, but there's certainly potential there. And, you combine machine learning with robotic instrumentation and robotic patient-specific instrumentation, I think there's a great deal of opportunity there. And right now, we're not doing a good job of understanding torsion in most of our deformities, because even the CTs that we had 10 years ago didn't capture enough tibia, and none of them capture the femur. So that'll give us an opportunity to look at torsion a little bit better as well.
Great comments. I agree with you 100%. If you could change one thing that you did, for good or for bad, what would that be? Did anyone ever ask you that? Probably yes.
I'm not sure that I could answer one thing, but I do wish I had realized earlier in my life that I had no interest in being a chairman, because then I would have skipped a whole bunch of committee work that got in the way of doing research and patient care, because I think you have to decide what you like. The wonderful thing about going to medical school is there are a lot of pathways. You can go into business, you can go into internal medicine, surgery, you can go to a pure research background. So you just have to figure out, I think, in your first 5 or 10 years, what's important to you. And I think changing locations is good for your brain too. Changing your job every 10 years or so, getting into a new environment where you have interactions with different people. I think that's probably better for your learning process than staying put at one institution your whole life.
I love that, of course, because I moved a lot, but also because I tell people, and I've never seen anyone say that, Dr. St. George, it just makes me like it more and more. But I tell all my fellows and all my trainees and the people that are above me, I will never chair anything. Don't even think about it, because I don't have time to pay attention and take care of shoulder surgeons and hip surgeons. I can barely do what I'm doing, so that makes me extremely happy. Francois, your turn.
I have a question. Of course, I'm very grateful for being able to interview you, Dr. St. George. We met a few years ago, and we were sitting next to each other at an IFAS dinner. I'm quite a shy guy, so I didn't ask you all the questions I wanted to ask you. But it was about JBJS, and at the time, Cesar had published in JBJS, and I think in the end, following in the footsteps of you and Cesar is a good way to get your papers there, not because it's prestigious, but that's where it has impact, and also impact on the other specialties. And I think cross-fertilization between fields is very, very important. But this question is simple. In your position, what advice would you give young researchers who are really passionate about what they found and really want to have the most impact amongst their colleagues?
So a two-part answer, I think, to that. First of all, if you want to publish in JBJS, learn about methods. So you can now get a bachelor's degree in biostatistics while you're a resident at some program. That would help immensely. Be free to write letters to the editor when you see something in the Journal of Bone and Joint Surgery that maybe doesn't meet a standard, because sometimes the papers don't. And that's how I initially was invited to be a reviewer, because I wrote a letter about a paper that I thought shouldn't have been published. And secondly, got me onto the editorial board, and then third, as a deputy editor. Those all followed. That was somewhat modulated by the fact that I was reviewing grants for two government organizations, and I began to crystallize the methodology, because you're surrounded by methodologists and people from other fields at those events, and you begin to see the flaws in the way we look at things. I'm clearly a clinical orthopedic surgeon, and I look at things from that perspective, but I really didn't see the impact of small or not so small flaws in the data collection integrity that are very common in the orthopedic world. And once you see that, you can improve the way you collect data, and improving the way you collect data will help you write a stronger paper.
Well,
and it might change your mind too.
That will definitely inspire us to get a lot of work done this year.
Final question. What do we have to do to have Bruce St. George and to come and spend a week with us in Durham, North Carolina to brainstorm about research?
Well, no, Zoom makes that easy.
But anyways, it's a huge pleasure and honor for us, Dr. St. George, to spend time with you and to interview you. I'm sure this is going to be an interview and a podcast that will stay there for a long time, and will for sure stimulate younger and young foot and ankle surgeons to think innovative, go for the data, choose the passions, and build a legacy like you have done. So I would like to thank you first for stimulating me to pursue what I have been doing. If I had to, even though Deland was one of my main mentors, I have so many mentors, of course, Lou, Sean, and Scott Ellis. It wouldn't be possible to mention all of them. But outside of my mentors that trained me surgically, you are the number one person that have stimulated me. So thank you for everything that you did so well. And it's a great honor to spend time with you. So for me, it's a big honor.
A pleasure for me too. And there's a reason you have so many mentors that are supporting you, because you go and do a good job and you get to the heart of getting things done.
No, it's my pleasure. Francois.
And I can only say that I'm very humbled and grateful to have taken part in this podcast. And so I wouldn't have anything else to add. If we can spend some time with you and show us some of our work and exchange and push the research forward, that would be fantastic. So thank you again for giving us this time.
My pleasure. Thanks for inviting me.
Thank you for joining us for this episode of the Foot and Ankle Clinics podcast with Dr. Bruce St. George. Foot and Ankle Clinics is available for individual print subscription with accompanying online access, or individual online-only access, and is also available on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter and subscribe to the Foot and Ankle Clinics podcast. Thanks for listening.